So we're going to do two topics. We'll get through prosthetic valves fairly quickly. It's not too complicated. Um, and then we'll get started into pericardial diseases. So we'll actually have two classes for the pericardial diseases. We'll do half today and then finish up next week. So for prosthetic valves are basically broken down into three main categories. First category we have are human tissue valves. So those are autograft or homograft. So the way I kind of remember the difference between the two is like auto, it's from within you, and then homograft is just from a human donor. So we're all Homo sapiens. So I remember homografts come from Homo sapiens. It's a human donor. So those are typically from cadavers, people that have expired. And then autografts are ones that are when we transplant the valve, our native valve, into another area. So typically it's the pulmonic valve that's resected and then placed into position of the aortic valve. And that procedure is called the Ross procedure. So with the Ross procedure, they're actually removing the pulmonic valve and then transplanting it into the area of the aortic valve. Because typically the aortic valve is the valve that's gonna, subject to the most abuse. It has to withstand those pressures. And it's usually the first valve to really fail. Unless, of course, the patients have rheumatic heart disease, then rheumatic heart disease, that typically, that attacks the mitral valve. But with this procedure, they remove the pulmonic valve, and in its place, they'll actually place like a synthetic tube or stent that has like a little synthetic valve over the right ventricle, and then connect it to the pulmonary arteries, and try and place that valve, in place of the aortic valve. So these autografts and homografts, these human tissue valves, the benefits of them is there's less regurgitation and less stenosis than your mechanical valves. So with any prosthetic valves, there's always going to be inherently a little bit of stenosis or regurgitation to varying degrees. The homografts and the bioprosthetic valves have less stenosis and regurgitation than your mechanical valves, but there is some to varying degrees. Some things that that unfortunately these human tissue grafts are not good for is they have I don't want to say life expectancies, but they're short-lived. They typically don't last as long as the bioprosthetic and the mechanical valves. And the same disease processes that attacked, the valve initially will attack these autograft and homograph valves. So they're also attacked by same disease processes. So with bioprosthetic valves, so these are made of animal tissue. The most common are porcine valves or pig valves from pig tissue. So those porcine valves, those are called our Carpentier-Edward valves. So they can also use bovine or cow, bovine valves. So that's typically the other option that they would use. Porcine are more common. You can also use bovine, so that's cow. And then your bioprosthetic valves are broken down into two categories. You have stented versus non-stented. So with your stented bioprosthetic valves, the valve is actually attached to a metal annulus, like a metal ring. And that metal ring is actually quite visible on echocardiogram. So it's easy to really differentiate, between like a native valve that's stented, I'm sorry, bioprosthetic valve that's stented and non-stented. With the non-stented valves, those valves are actually attached directly to the valve annulus. Just gonna erase this side for a second. So bioprosthetic. So these valves are going to be typically used for younger patients. Because of lack of need for anticoagulation. So with mechanical valves, those patients have to be on anticoagulation therapy for the rest of their lives. There's no ifs, ands, or buts about it. So when we have the younger patients, kids that may have like valve, abnormalities, say they have like a bad aortic valve, bicuspid aortic valve, or a stenotic valve, or they've, had any sort of congenital abnormalities, they'll go to the bioprosthetic valves because they don't want to have these poor kids doing anticoagulation therapy at such a young age. The bioprosthetic valves, typically last from 10 to 15 years. In addition, they also have less regurg and stenosis than your mechanical valves. So then with mechanical valves, so there's basically three main types of your mechanical valves. So you have your first one is the Starr-Edwards valve. So that's your ball and cage. So the way to visualize it is like, this is the valve annulus, and there's like a cage that sits on top of that annulus. And this ball that's inside the cage goes up and down and closes the opening. So it would be like connected like that. So blood flow is trying to get out. And like with systole, you know, it pushes the ball up, and then diastole, when you get that change in pressure, the ball comes down and stops the blood flow. So all mechanical valves will have regurgitation and stenosis associated with them. The second type of valve would be a single tilt valve. So this is called a Bjork-Shiley valve. I don't know if you could see that, Bjork-Shiley. So with that, you have your annulus that's supported with a single disc that kind of tilts open and closed like that. And then they created something called a double tilting disc. So if you think about it, you now have two discs that kind of open and close. They swing open and close. And this one is your St. Jude valve. So these may show up on your registry, these different names. The Bjork-Shiley single tilt, Star Edwards, your ball and cage, and St. Jude is your double tilting disc. And you'll be able to recognize the differences between the two based on their regurgitant jets. So if you think about this one, when it closes, and you get that ball sitting there, your regurgitant jets are kind of going to be eccentric coming out the sides where that ball is. The single tilting disc, the regurgitant jet, you'll wind up with two jets. Which will also typically be more eccentric. And with your double tilt disc, you'll have two on the side and one smaller central disc. Like, so you'll have your three jets with like a double tilting disc. So your double tilting disc. So that's the one that they typically use now. That's the most common mechanical. This is going to be your least restrictive. Sorry. Allows for more laminar flow. And so advantages for mechanical valves, they're very durable. And disadvantages: require anticoagulation therapy. Require anti. So more stenotic. More regurg. They're also prone to developing embolus. Going to develop embolus. Another disadvantage too, when we're imaging, you have a shadowing from the valve. You think about it, these things are metallic, they're metal. So metal is one of our enemies too in ultrasound. So sometimes we can't necessarily get a good clear picture, of the valve itself due to the shadowing from the valve. On echo exam. So some of the things that we're going to look for. So we're going to try and figure out, we need to know the type and size of the valve. So these valve replacement patients, they're typically going to have a card that the surgeons give them that'll say the type of the valve and the size of the valve, because these valves come in different sizes, because we're all different sizes. And that's going to affect your calculations when you're trying to calculate, stenosis. So we'll be able to have, the exact valve areas, valve surface areas, in order to input those into the equations to calculate, continuity equation. So on echo exam, we need to know the type and the size of the valve. We're going to Doppler velocities. So like I said, all mechanical valves inherently have some degree of stenosis or regurgitation. So when we're assessing mitral valve, we now have new peak velocities in order to determine stenosis. So peak velocity greater than 2 meters per second indicates dysfunction. Mitral valve. And peak velocity greater than 3 meters per second. For aortic valve. Another thing to remember too for valves is we have to use the continuity equation. Continuity equation must be used. Under here we'll put no pressure time. We're also going to assess regurg jets. So those bioprosthetic and I guess I'm going to say auto homographs. We typically have one regurg jet mechanical two or three jets, depending, on valve. Depending on type. We're also going to assess for perivalvular leaks. So paravalvular leaks, valvular leaks. We're going to look for dehiscence. So dehiscence, that's when the valve is actually separating from the annulus. So that's valve separation. Annulus. So with dehiscence, you may see a rocking motion of the valve. So rocking motion valve. As well as perivalvular leaks.
Where would we see a paravalvular leak?
I'm just going to do like mitral valves. So it'd be leaks along the sides where the valve was attached to. So on the sides of the, sorry, there we go. So the leaks would be coming from the sides. So paravalvular. So on echo, you might actually see the valve kind of rocking a little bit. So you're like, oh, it's starting to come loose. It's not this, the sutures or the stitches, that are holding the valve in are starting to come loose. So that's what dehiscence is, that separation of the valve. So, I mean, that can happen to a native valve, and that's no bueno, if that's happening to your native valve. But I mean, these valves that they now attached in and sewn in, sometimes they can get loose, the stitching can get loose, so they start to separate. So you can start seeing a little motion, some rocking of the valve. And then you're also looking for leakage around those suture sites where it was connected. So that's the paravalvular leak. So it'd be like small little like regurgitant jets around that. Or I mean, I guess they could essentially be in both directions if it's starting to get loose. And I guess the last thing that we would be looking for too would be, particularly with mechanical valves, it's like look for thrombus. Look for thrombus with mechanical valves. Yes, we can also add, oh, I forgot to ask you to add also, we're also assessing too for endocarditis. Assess for endocarditis. So that's your vegetations. Vegetation. Let's go back. I'm gonna do pericardial effusion. So with pericardial effusion, probably the most important thing is really being able to differentiate between, pericardial effusion versus pleural effusion. So we can do this in our parasternal long axis view. I'm the worst drawer ever. So does anyone know what that is? If we're doing our parasternal long axis, you see a little anechoic circle outside your image there?
Descending aorta.
Yes, very good. So that is our descending aorta. So we use that as kind of our frame of reference when we're trying to determine if it's a pericardial effusion versus a pleural effusion. So our pericardial effusions will typically be more anterior to that descending aorta, whereas a pleural effusion will typically be behind the level of that. So our pericardial effusions will go around the heart. So this will be our pericardial layer, pericardium. So this would all be fluid in here. And then this would be a pleural effusion in the lungs. So in your parasternal long axis view, your pericardial effusion is going to be anterior to that descending aorta, whereas your pleural effusions you're going to see posterior to it. So that whole area. Another thing to remember too with pericardial will not change with respiration. So we can actually measure. So the doctors may ask us to actually measure how much pericardial effusion that we see. So when we're measuring, we want to measure during diastole. I want to just check on our PowerPoint because I don't know if my numbers for grading are old or not. Let me see. Because I know severe was greater than 2 centimeters, but I have as small as like greater than 0.5 centimeters. So let me just see what our PowerPoint says. Courses. So they have small as less than 1. Okay. Or greater than 1, sorry. So we'll do that. All right, so then for grading, small would be greater than 1 centimeter. Moderate, 1 to 2 centimeters. And large would be, I'm sorry, wrong way. God, I'm dyslexic. Greater than 2 centimeters. There we go. So some causes. First is going to be infection. It's pericarditis. So we can also have malignancy. Heart failure. Now, post MI. So under here, we have a condition called Dressler syndrome. We also have cardiac trauma. Status post cardiac surgery. Hypothyroidism. Hypothyroid. Recreational drug use. Aortic dissection.
Dan, is the fluid that's in there blood or is it like like
No,
other
so it's
stuff?
no, it's more serious fluid. So if it's a result of an infectious process like pericarditis, so it's going to be like white blood cells, like kind of lymphatic fluid, like all the kind of like all the stuff that goes into like healing. When you get an infection, like inflammatory. No, it's not.
Okay,
I mean, it could potentially be blood if it's more due to like cardiac trauma.
right.
Post
I mean,
surgeries.
there's different types of like effusions. So I mean, like I know when I get into like abdominal sonography, we have something called malignant ascites. So when a cancer patient has ascites due to cancer, it has a little bit different appearance to it. It's kind of like striated. It's not just simple clear fluid. So that's a good question though, but it could potentially be blood if it's like more of a trauma issue. But when it's infective, it's more like it's just more serous fluid. Some other causes could be radiation. CHF. Or it could also be idiopathic.
Dan, what does that second one say? Aortic.
Dissection, sorry.
Okay, thank you.
idiopathic. So if the effusion is large enough on that parasternal long axis view, we can sometimes also see it above the right ventricle. So if we have our parasternal long axis view, we see a portion of that right ventricle up there. We can sometimes appreciate fluid, above the right ventricle as well, going around the right ventricle. So, and also be seen in subcostal. So that could be another potential view to appreciate pericardial effusion. And apical four-chamber. So effusions first start collecting behind right atria, RA, due to lowest pressures. So that chamber has the lowest cardiac pressures. So to answer your question, Morgan, so if effusion looks, I want to say, what they say, loculated. So loculated meaning like there's like kind of a stranding. It is likely blood or pus. So if it's blood or pus, it's more dangerous than simple fluid. So this is more dangerous. Simple fluid. The reason for that is it doesn't flow as nicely. So when the heart's trying to expand and contract, it's met with more resistance, you know, if it's pus or if it's blood or blood that's starting to clot a little bit. So that leads to a higher risk of developing tamponade. And it's also harder to drain as well. So it's more dangerous than simple fluid. So not as, I don't want to say hemodynamically fluid, you know, I don't want to say hemodynamically fluid. So not as fluid. Restricts motion, restricts motion. Harder to drain. Harder to drain.
So is that how you treat pericardial effusion? You like poke it and drain it?
Yes, if it's significant, yeah. They would try and tap it out.
Can they do that from the outside or do they have to like open you up?
No, it's a percutaneous, yeah. Like go through your chest wall.
Sounds fun. All right, so a little overview for the pericardium. So the pericardium, you know, consists of 2 layers. We have the visceral pericardium, which is continuous with the epicardium, and the parietal pericardium. That's the thick sac that surrounds the heart. So I think of the visceral pericardium as the one that actually is in contact with the heart itself. So visceral, I think of the organ, like visceral is an organ. So the visceral layer of the pericardium is the one that's in direct contact with the heart. So it's continuous with the epicardium, so that outer wall of the heart. So think of the pericardium as kind of like a sac around the heart, has two layers. The visceral side is the one that's the inner side that's in contact with the heart. And the parietal is the outside layer that's kind of in contact with the outside, or I guess, the outside chamber, the mediastinum. So normally there is between 5 to 10 milliliters of fluid within the pericardial layers. So the pericardium encloses all 4 chambers of the heart and extends up the great vessels. So pericardial effusions can accumulate due to infectious and processes of the pericardium. Most of these processes involve both layers of pericardium. So here's just some etiologies, for pericardial disease. Idiopathic, we have infectious. So it's viral, bacterial, fungal, inflammatory processes. So we can add on there rheumatoid arthritis or lupus, post-MI. After there, we have Dressler syndrome. So associated systemic diseases, we saw hypothyroidism. We can also add cirrhosis or amyloidosis, malignancy. Under miscellaneous, we have trauma, post-surgical, radiation therapy, CHF. Oh, pregnancy too. You can add that on there. Oh, so then we have under pericarditis. So that's your infectious processes. So acute pericarditis can result of any etiology and may result in variable amounts of accumulated fluid within the pericardium. So pericardial space size is limited. Therefore, when there is a fluid collection in the pericardium, it can affect volume within the 4 chambers of the heart. It is also dependent upon the compliance and distensibility of the pericardium. Due to this, a large chronic effusion may have little or no effect on the hemodynamics of the heart, while a smaller acute effusion may have more significant effects on the heart. So it's important, to remember that, like, something that happens acutely, it's suddenly, very fastly, the heart will not have time to accommodate. So a small effusion that develops quite rapidly, say it's due to trauma and it's blood that's developing in the pericardial space, will have an acute impact on the heart, and those patients are more likely to wind up in tamponade, as opposed to something that's happened over a long period of time and the patients, say, developing a pericardial effusion as a result of like slow progressive CHF. The heart may have time to accommodate, for that large amount of fluid. So you put the probe down, you see a large pericardial effusion, you're like, oh my God, and this patient, they're fine. They're talking to you. There's really not that much hemodynamic effect on the heart because that heart's had time to accommodate for that little bit, for that, large amount of fluid. So pericardium can be evaluated in 2D, M mode, and 3D echo, as well as intracardiac echo. In the absence of pericardial effusion, thickening or calcification of the pericardium is difficult to visualize. So we could see here some pericardial effusion. Over here, you see a little bit there too. So utilize multiple views. Long axis, short axis, apical, subcostal to see the full extent of pericardial effusion. So again, a small effusion is defined as less than 1 centimeter of fluid around the heart. Moderate 1 to 2 centimeters. And a large pericardial effusion greater than 2 centimeters of fluid. This is just saying, pericardial effusions, they may not be simple fluid, it may be loculated fluid and can be localized instead of circumferential around the entire heart. So you may just have an effusion in one focal area. All right, so here's a good picture showing, the difference between what a pleural effusion and the pericardial effusion. So your pericardial effusion is going to be anterior to that descending aorta. And you may also see some anterior to the right ventricle up here as well. And then you see your pleural effusions are going to be, posterior, run posterior to that descending aorta.
So you just measured like the pericardial effusion on 2D echo?
Yes.
Like-
Yeah, 2D echo, will give you your most accurate measurements. And again, measuring during diastole.
Oh, okay.
So here you could see both pericardial and pleural. So this would be your pericardial effusion. So here's your descending aorta. And then, this would be your pericardial effusion over here. This is a little bit of lung actually that you're seeing here. And this is all your pleural effusion. So that looks pretty significant. So here's another one. You can see your pericardial effusion. It's your large pleural effusion. The aorta. See how it runs, anterior to that aorta. So this is your parasternal long axis view again, your LA, LV. So in the presence of calcific pericarditis, there is usually shadowing under the pericardium due to excessive bright echoes of the thickened calcified pericardium. So in the presence of pericardial effusion, masses and stranding can also be visualized within the fluid collection. It can occur on either the visceral or parietal pericardium. Detection of stranding or masses are indicative of an inflammatory or possibly hemorrhagic or even malignant etiology. Let me get into a condition called cardiac tamponade. So this is when increasing amounts of fluid results in hemodynamic compromise to the heart. So when the pressures within the pericardial space exceeds that inside the heart, hemodynamic changes will start to occur. So again, so these are some causes for tamponade. So it's basically, same causes that we would have for your pericardial effusions. So clinical presentations, patients will have chest pain and shortness of breath, difficulty breathing, dyspnea. They can also be tachycardic with narrow pulse pressures. Elevated jugular venous pressures. There's something called Beck's triad, which is increased venous pressure, decreased systemic blood pressure, and quiet heart sounds.
So cardiac tamponade only occurs when there's like a pericardial effusion or some kind of like effusion?
Yep.
Okay, cool.
Yeah, so tamponade is a result of the effusion. So tamponade. So this could eventually, like, as tamponade progresses, the heart can essentially, like, the blood flow in the heart could stop moving because the heart, relies on pressure differences, to circulate the blood. So when you have increased pressures on the outside of the heart, it's going to directly affect the hemodynamics inside the heart and could eventually lead to the heart just kind of stopping, like the blood flow in the heart just essentially stopping. So we're going to put, cardiac tamponade definition. So the definition of tamponade would be cardiac function impairment due to external pressure on the heart. This is tamponade, cardiac function impairment due to external pressure on the heart.
So with tamponade, fast accumulation is worse prognosis. And then, so on echo, you may see right atria / right ventricle diastolic collapse. So if we kind of think about it, we have, fluid building up around the heart. The first place it's going to affect are the atria because those are lowest pressure. So it's kind of squeezing on the atria, particularly the right atrium. So if we are squeezing that right atrium and increasing the pressure in that right atrium, it's going to affect our venous return to the heart. So we're going to have elevated pressures within the venous system. So that's why we wind up with that, venous hypertension. It's going to change, the venous flow patterns. And we also have impaired cardiac filling, due to changes in pressure gradients. So atria affected first in systole. So the reason they're affected first during systole, that's when the atria should be filling. So we have that increased pressure, so the atria aren't filling properly. And then ventricles are affected after atria during diastole. Affected. After atria during diastole.
tamponade. So eventually, all 4 chambers will have equal diastolic pressure.
All right, so ventricular filling is impaired and cardiac. So ventricular filling during diastole is impaired and cardiac output is decreased. Intrapericardial pressures is influenced by both volume of fluid and the rate at which it accumulates. So as we said, a fast accumulation is worse than a chronic slow accumulation. So Doppler findings of pericardial effusion. So for tamponade, we see diastolic right ventricular collapse, right atrial collapse, exaggerated respiratory variation and inflow velocities. So cardiac tamponade is the clinical diagnosis. Echocardiography may suggest a hemodynamic abnormality that may be substrate for tamponade. Echo alone does not make a diagnosis for tamponade. So you can have something called a swinging heart. So this is something that could be seen with large pericardial effusions, where you actually see the heart rocking back and forth within the fluid. It can be used as a sign of cardiac tamponade, but is not simply a marker, but it is simply a marker for a large effusion. Large effusion is more likely than small effusion to have increased intrapericardial pressures. So again, echo findings with cardiac tamponade. So these are more specific signs of hemodynamic compromise. So diastolic right ventricular outflow collapse, an exaggerated right atrial collapse during ventricular diastole, right ventricular collapse during systole can be documented on M mode. So here we have the M mode going through the right ventricle. see over here. So this is during diastole. This is our mitral valve open. All right, are we in aortic valve? Oh, I can't tell. So the right ventricular outflow tract is likely to be more compressible. With significant elevated intrapericardial pressures, this area tends to collapse. Exaggerated right atrial collapse can also be seen as an indication of impeded right atrial filling. So these can be best visualized subcostal or apical views. So Doppler findings for tamponade, Doppler of the mitral valve and tricuspid valve inflow, and aortic and pulmonic valve outflow should be performed. There's some degree of variation seen in respiration. With cardiac tamponade, there's exaggerated respiratory variation affecting the tricuspid valve first. So here we could see exaggeration of the respiratory variations. So respiratory variation with inspiration for pericardial tamponade, we'll have decreased mitral E velocity. And with expiration, we'll have increased mitral E velocities. So here we have inspiration, expiration. So we see with inspiration, we have decreased mitral E velocities. And with expiration, we get increased mitral E velocities. So echo guidance for pericardiocentesis. So the first role of echo is to diagnose the pericardial effusion and any hemodynamic compromise. So if they decide they're going to drain the fluid, the effusion should be observed from multiple views to determine the distribution of the fluid, where the largest pocket's going to be, where the easiest access is. Some facilities use echo-guided pericardiocentesis to help visualize the tip of the needle as to not damage the cardiac structure. So you can see this is a very large effusion. And the echogenic portion here is going to be the needle tip. So the needle's kind of coming down here. The ultrasound machines now are actually quite good at visualizing the needle tips. This is kind of not such a hot picture, but it looks like the needle's coming down this way. And this is the needle tip here.
Does the drained, like after you poke it, does the drain fluid just like reabsorb into the body?
So we're actually draining the fluid out, like
Oh,
extracting.
you
it
like
out.
sucked it? Okay.
Yeah, so it's a syringe. So it's a needle with a syringe and they're like, sucking it out and actually draining the fluid. So more commonly in today's practice, constrictive pericarditis is a result of infectious or inflammatory processes such as connective tissue disease or radiation therapy. Can also develop several years after cardiac surgery. Constrictive pericarditis occurs when there's stiffening and usually thickening of the pericardium that constricts diastolic filling of the heart. So the pericardium forms a rigid shell around the heart. And there is an elastic constriction in which there is a variable transmission of intrathoracic pressures to intracardiac chambers. So with constrictive pericarditis, it's a thickening and a stiffening of the pericardium and results in elevated diastolic pressures. And these findings and pathophysiology are similar to cardiac tamponade. So multiple clinical and anatomic, physical, and physiologic observations must be made in order to diagnose restrictive pericarditis. There are no specific echo or Doppler findings that are complete indicators of constrictive pericarditis. So although pericarditis is defined as thickening of the pericardium, it's often difficult to assess on 2D echo. In the presence of pericardial and pleural effusions, the pericardium can be measured. So a normal thickness is 1 to 2 millimeters. So etiology of constrictive pericarditis may develop in the aftermath of virtually any pericardial injury or inflammation. Some signs of constrictive pericarditis, would be chest pain and dyspnea. Physical findings, we have jugular venous distension, edema, ascites, pulsus paradoxus, hepatosplenomegaly. So some auscultatory findings when they're listening to the heart, could be a pericardial knock caused by early rapid diastolic filling followed by a prominent halt to flow. So for constrictive pericarditis, 2D and M mode findings, you have your thickened pericardium. We have normal LV and EF. Respiratory variations and ventricular inflow. We'll typically have enlarged atria. We can have flattening of the LV posterior wall and diastole. Abrupt posterior motion of the ventricular septum in early diastole. So this is a dyskinetic ventricular septal motion. We have dilatation of the IVC and hepatic veins. You can see ascites. So echoed echocardiogram recorded in a patient with constrictive pericarditis. Note the flat position of the posterior wall during diastole after initial rapid filling. Also note the abnormal ventricular septum, the double arrows. I was referring to here how during diastole, the posterior wall appears flat. So Doppler findings. So we have respiratory variation in flow velocities, typically restrictive mitral inflow patterns. So our restrictive mitral inflow patterns, we're going to have our increased E wave and decreased A wave. Increased E. E wave. Decreased A wave. Big E, little a. We'll have a restrictive mitral inflow pattern, similar to our restrictive diastolic dysfunction. Because this is it's a diastolic dysfunction, this restrictive pericarditis. I'm sorry, constrictive. Oh, that's gonna stay with me, huh? All right, so constrictive pericarditis versus restrictive cardiomyopathy. So both will have, so marked bilateral biatrial enlargement in restrictive cardiomyopathy with relative normal chamber sizes in constrictive pericarditis. So you'll have some atrial dilatation, but not as significant as with restrictive cardiomyopathy. Lack of respiratory variation in restrictive cardiomyopathy and increased constrictive, and it is increased with constrictive pericarditis. Tissue Doppler imaging, more rapid early relaxation with constriction versus restriction when diastolic volumes are diminished below normal. So this is mitral annular tissue Doppler imaging recorded with the patient with constrictive pericarditis. Note E prime velocity of 28 centimeters per second, which may be a distinguishing feature when differentiating from constrictive versus restrictive physiology. So more rapid early relaxation with constriction versus restriction. There you go. So with constrictive pericarditis, the pericardium appears thickened and bright. You have an abnormal septal motion. So we remember with restrictive cardiomyopathy, we still have preserved normal systolic function, so that septum shouldn't be affected. So we shouldn't have abnormal septal motion. Where with constrictive pericarditis, we have abnormal septal motion. So our E to A will look similar, as well as the deceleration times. But then when we're doing our annulus with constrictive pericarditis, our E primes will appear normal. Well, we'll have reduced velocities with restrictive pericarditis. I'm sorry, restrictive cardiomyopathy, gosh. In addition, with constrictive pericarditis, pulmonary hypertension is rare. We often have pulmonary hypertension with our restrictive cardiomyopathy. We'll have exaggerated respiratory variations with our pericarditis. And we also typically don't have regurgitation, whereas with our restrictive cardiomyopathy, we frequently have regurgitation. So we've already been over restrictive cardiomyopathy. You know, the principle is abnormal diastolic dysfunction. So we know restrictive cardiomyopathy is idiopathic or secondary. You know, it's a heart disease, heart muscle disease, creates stiffness of the myocardium, which causes pressures within the ventricles to rise quickly with small increases in volume. So it's a form of diastolic heart failure. Systolic function is typically normal. Again, for restrictive cardiomyopathy, we know it's idiopathic, infiltrative cardiomyopathy. Amyloidosis is the most common cause. We also have carcinoid syndrome, glycogen storage disease, sarcoidosis. Could also be treatment induced, perhaps from radiation treatment or malignancy. So restrictive cardiomyopathy treatment is often unsatisfactory. Prognosis is usually poor in adult population with progressive deterioration. Prognosis is especially poor in children with heart failure. Patients who do not respond to therapy usually die of low output cardiac failure unless cardiac transplantation is an option. This kind of just goes more over restrictive cardiomyopathy. So complications, thromboembolism within the atria, dysrhythmias. So these patients, wind up with AFib, cardiac cirrhosis, progressive deterioration of cardiac function. So we have marked biatrial enlargement. On echo, we see diffuse speckling and granular appearance of the myocardium, particularly with amyloidosis. It's often associated with pericardial or pleural effusions. We typically have mitral and tricuspid regurgitation, and we know that the worse the MR and the TR, the worse prognostic indicator that's going to be. So the worse the regurgitation, the worse the restrictive cardiomyopathy is going to be, the worse the outcome. So it's kind of just a snowballing effect. For our mitral valve, we have big E, little a, E to A ratio greater than 2. We have decreased deceleration times of less than 150. But there's not going to be a significant respiratory variation. Tricuspid valve will have restrictive filling. So again, we'll have increased E to A ratios and short deceleration times. With our restrictive cardiomyopathy, we wind up with pulmonary hypertension because everything's backing up due to elevated atrial pressures. So we have dilated pulmonary veins, pulmonary congestion. So with restrictive cardiomyopathy, our E prime ratio to assess left ventricular filling pressures. So E prime is going to be greater than 15 as a result of elevated filling pressures. So our diastolic dysfunction assessment, abnormal relaxation pattern with the E to A ratio that is less than 1. So that's when we have our little e and bigger A, and we have longer deceleration times. Then we enter into stage 2, that's pseudo normalization, where our E to A ratio and deceleration times appear normal. We can have the patient Valsalva during that pseudo normalization stage. And when they Valsalva, we'll see a reversal. We'll instead of a normal appearance, we can get a reversal of the E to A ratio. So that's how another way we can unmask, this pseudo normalization. We have the patient Valsalva. And then during restrictive, that end stage of diastolic dysfunction, we have large increased E to A ratio. So big E, little a. We now wind up with fast deceleration times or shortened deceleration times. So treatment, we treat the underlying etiology, diuresis. So we try and, decrease blood volumes, take pressure off that the atria. ACE inhibitors, they need anticoagulation due to risk of developing thrombus within the atria and development of strokes. Antiarrhythmics, so we medications to try and correct the AFib, pacemakers, and eventually cardiac transplantation. So we can also have a congenital absence of pericardium. So this can either be a partial or complete. It's more frequent in males. So maybe asymptomatic or the left atrial appendage more frequently than the right atrial appendage, can become herniated through the pericardial defect and become strangulated, and this may cause symptoms. So these patients may have an abnormal or unusual echo windows because the pericardium is kind of what's holding that heart in place. So when there's absent pericardium, the heart may actually shift or swing. So abnormal or frequently there has been reported of paradoxal ventricular septal motion. So we can also have pericardial cysts. So pericardial cysts are benign developmental abnormalities that are most commonly found near the right atrium. So these cysts can actually displace the heart. They can range in size from 2 centimeters all the way up to 16 centimeters. Most common age is between 30 and 50 years old. And it's important to differentiate them between a pericardial effusion or a dilated coronary sinus versus a pseudoaneurysm or potentially even a mass. So we know cysts are, they're completely anechoic, they're well circumscribed. They're going to be similar dimensions in both long and trans. So if you turn on the cyst, it should appear a circle, and no matter how you turn on it. We can also have pericardial tumors. So pericardial tumors, primary tumors are rare, but mesothelioma can involve the pericardium. So you can have pericardial clots, cysts, lipomas, or teratoma. Can be intrapericardial, but these are benign. Teratomas are popular with the DMS girls and with doing OB. So teratoma is basically like cells that are comprised of teeth and hair, and like usually you would see teratoma like when you're doing a pelvic ultrasound. So metastatic involvement of the pericardium occurs more often due to associated carcinoma of the lung, breast, melanoma, lymphoma, leukemia. So more often than not, if we see a tumor within the pericardium, it's going to be a metastatic. And commonly it's from the lung or the breast and melanoma. Those are like your 3 big ones. Just because of the proximity of the lungs and the breast cancer. So characteristics metastases include echogenic structure without distinct borders located on the pericardial surface. Metastatic involvement usually is associated with large pericardial effusions with or without signs of tamponade. We can also have myocarditis. So this is inflammation of the muscle of the heart, the myocardium. A wide range of infections and other problems can lead to myocarditis and often develops in people who are otherwise healthy. When you have an infection, the body produces cells to fight the infection, and these cells produce and release chemicals that can enter the heart and damage the myocardium. The heart can become thick and swollen and weak. So with myocarditis, viral is the most common cause. So these are just a list of some viruses that can cause myocarditis. Coxsackie B virus, Epstein-Barr virus, cytomegalovirus, Hep C, herpes, HIV. It can also be bacterial causes like chlamydia, streptococcal, staphylococcal. So fungal or parasitic infections can also be a cause of myocarditis. Some other causes could be chemicals or allergic reactions to medications. And then autoimmune diseases that can cause inflammation throughout the body, such as lupus or rheumatoid arthritis. Some signs and symptoms. So often there are no symptoms, but if there are, the shortness of breath during exercise, abnormal heartbeat that may cause fainting, lightheadedness, chest pain, fatigue, different signs of infection like fever, muscle ache, sore throat, painful joints, joint swelling. So it's kind of non-specific symptoms if you really think about it. So for treatment, you have to treat the underlying cause. We can administer medications to improve heart function, like ACE inhibitors or calcium channel blockers, diuretics. Rest and reduce activity for 6 months. So we want to give the myocardium a chance to relax, and heal. Want to refrain from, exercise and physical activity, a low salt diet. Patients may be hospitalized if he or she develops a blood clot or a weakened heart. So if as a result of the myocarditis, they start developing a blood clot or have an abnormally weakened heart, they could potentially be hospitalized. They could be hospitalized, if they have abnormal heart rhythms are severe. The patient may require a pacemaker or a defibrillator implanted. An outlook depends on the cause of the myocarditis and the patient's overall health. And one may never fully recover from myocarditis. Complications, if untreated, may lead to heart failure. In rare cases, cardiomyopathy and pericarditis can occur. So myocarditis, along with cardiomyopathy, are the leading causes of heart transplant in the US. In rare instances, myocarditis can lead to sudden death. So just a couple of things I just wanted to add under for, from my notes. So for congenitally absent pericardium, so. Congenitally absent. So parasternal long axis. Heart is shifted to left. And we see more right-sided structures. The right ventricle will look bigger too, RV. So I'm gonna put, big RV. And it can be associated with ASD, bicuspid aortic valve, bicuspid valve. So then we also have some treatments for constrictive pericarditis treatments. For we can have pericardectomy, pericardiectomy. Gosh, pericardiectomy, pericardial stripping, stripping. So they can actually surgically remove a portion of the pericardium, to relieve the pressures, particularly on the atria, to improve your diastolic function. So if it's a choice between, squeezing the life out of your heart and removing that pericardium, they'll do that. So, actually put, remove pericardium, remove pericardium. Any questions about anything?
Yes, when we have a test on that.
I don't think our next quiz is until April. I think we have a good.
April is pretty soon, like in
Not that soon.
in a few days.
Few days, couple weeks. I think
Yeah.
it's April 9th, I want to say, something like that.
So at least in 2 weeks, it's a kind of very it's a lot of information, like long lecture.
Yeah, we got it in 2 hours. Yeah.
So, did you guys just mention that? When's the quiz?
I can double check. I think I want to say April 9th is when it was. Double check.
Thank you.
Contents.
Because it'll also be the info we cover next week too, right?
Mhm.
Yeah, I actually
Seems like-
was anticipating this would go longer. I don't think I have, let me see what's next week. Let's search on the docket. Yeah, myxomas and tumors and masses. Yeah, so I think it's next week too.
Okay.
Yep. Start here. Wait, hold on, syllabus.
Oh, except next week, oh wait, no, that's the 2nd. Never mind. I was like, wait, next week we don't have class, but it's April 2nd that we don't have class.
So quiz is on 4/9.
It's the next week we don't have a class?
No, the week,
No, the
like
week
April,
after.
April
After.
2nd.
Yes. So next week we have a lecture.
Yeah,
April 2nd, no class.
yep,
Then it should be April 9.
April 9.
Yeah,
Yep.
Yep,
Yep.
yep.
Mhm.
And actually, you know what? It's the next week's, we're actually ahead of schedule.
Wow.
Yeah, so we can. If there's anything else like we want to go over, like with the endocarditis and did we do we didn't do endocarditis. We have to do endocarditis. Or we just did pericarditis. Next week will be endocarditis.
And myxomas.
And myxoma, we could start, if we have time, we'll start into myxomas. Myxomas isn't for quiz 5, so that's on quiz 5 on the 23rd. Myxomas and aorta and great vessels. That's 23rd of April.
Sounds good, Dan.
Good. Anything else? Enjoy your weekend, have fun, get outside. Sun's
Thank you.
actually coming out.
Nah, not outside. It's maybe tomorrow.
Maybe tomorrow. Sun's coming out.
Yes, tomorrow. Should be nice.
Dan, did you get a chance to email CDC and see if it's cool if I stay until 4 again?
Sure, yeah, I'll do that right now. I'm
Okay.
sure it is.
I mean, yeah, I don't see why it wouldn't be.
Yeah, I'll
Um,
just double check with them.
And can I get there at 7:30 again too? Just like, I don't know what time they open, so just like ask them that too.
Okay, 7:30, you got it.
Thanks, Dan.
All right, I'll let you know. I'll email you. Hopefully they get
Okay,
back to me.
cool. Thank you.
Do you start Monday? Is that where you start?
Yeah,
Monday?
CDC is where I go Monday.
You know what? I'll
and
call them directly.
then- Look
Instead.
at you.
Oh,
Okay.
yeah, let's see. chances are they won't reply to email on a Friday, right?
Good point. Okay, cool. Yeah, so I can be there 7:30 to 4 just because I have that like other class at 4:30 that like evening.
Sure. Alrighty,
Awesome. Thank you.
you're welcome. Take
Bye,
care.
y'all.
Bye.
Bye.
Nice weekend. See you.
Bye.
Have a good one.